Oh, hey, I need a gurney here! Now!
Alright, hey guys, welcome back to the channel. In this video I'll be reacting to this new TV show called The PITT. There's a lot of neurology in it and pain medicine, and so I thought that it would be interesting for you to check it out and get a better understanding of the real medicine behind it. If you're new to the channel, welcome. My name is Dr. Seizure. I am a double-boarded neurologist and interventional pain doctor. Alright, let's get started. Okay, so this guy looks like he's having a seizure. You can see rhythmic shaking of his arm, and then also basically what we call a figure of four. So if you have a seizure, a lot of times what would happen is that the part of the brain that is having excess electrical activity will be hyperactive. So let's say it's the right side of your brain, then it will lead to movement on the left side of your body, because the right side controls the left side of the body. So that's why you're gonna see that rhythmic shaking happen on the opposite side of where the seizure focus is. Sometimes it will start in a specific part of the brain, but then it will spread. So that's what we call a generalized tonic clonic seizure. And so that's essentially what it looks like is happening right now with this guy. Now, we don't know why he's having a seizure. So let's keep watching and see what's going on.
Lorazepam's on board.
Okay, drop another 4.
So basically, when somebody is having a seizure, we use what we call a benzodiazepine, or a benzo is what we call them. So things like lorazepam, diazepam, these are all benzos that essentially we use. They can be rectal, they can be intramuscular, they can be intravenous, because obviously when somebody is having a seizure like that, they're not going to be able to take it orally. So that's the advantage of having those medications. These medications work by depressing the nervous system. So we're trying to decrease the neuronal firing that is leading to the seizure. And that's only half of the treatment. So that's the first half, which is basically aborting that seizure. So that's the acute treatment. But then the second half of the treatment is to make sure that you are preventing another seizure from happening. So what we call prophylactic treatment. And that would be with anti-epileptic medications. Let's see if they're gonna give that or not.
Another 4 milligrams?
Can't get the top off.
I mean, in real life, I've never had to open a vial of lorazepam or any medication for that matter. You usually have nurses around and other team members who are doing that.
If this doesn't work, we need to prep keppra.
Okay, so she's saying that if this doesn't work, we need to prep keppra. So yeah, I mean, normally we would give keppra concurrently with the benzodiazepine if somebody is having a prolonged seizure or they are in what we call status epilepticus. Status epilepticus used to be defined as half an hour, so 30 minutes of seizure-like activity. But obviously, with 30 minutes, your brain is fried, so nobody waits 30 minutes. Normally, even 5 minutes of prolonged seizure activity without return to baseline, we call that status epilepticus. And the protocol and the treatment for this is not only the benzodiazepines, but also we usually load with an anti-seizure medication that can be given IV. And the 3 main options that we use are keppra, which is levetiracetam, we use phenytoin, and we use valproic acid. The latter 2 are older medications, but we still use them sometimes depending on the patient and their comorbidities, if we know what kind of conditions they might have.
He's already had 8 milligrams. He'll stop breathing.
Then we'll intubate. Sometimes the patient needs a little more.
Okay, so here they're saying that he's still seizing, and despite the benzo, and they might need to intubate, which is true. A lot of times for airway protection, intubation is necessary. And also these medications, so the Ativan and the benzos, actually will depress your respiratory drive as well. Sometimes we even have to go for something stronger like propofol, so essentially inducing anesthesia if the patient is not responding to those benzodiazepines.
I want to move on to keppra, but Dr. Langdon disagrees.
Okay, so this is a good depiction of a seizure. It looks pretty real. You can see the guy foaming at the mouth. Other things that can happen during a seizure include incontinence of urine or even fecal incontinence. Tongue biting can happen. And we already talked about the rhythmic shaking. The eyes can be deviated sometimes, depending on what part of the brain is having the seizure.
Dr. Santos, what is the definition of status epilepticus?
Seizure lasting more than 5 minutes?
Okay, so it's status epilepticus, not eucalyptus or whatever he said, but close enough. Yeah.
Ordering CBC, CMP, and a straight cath for urine tox.
Now, Now, when somebody is having a seizure, a lot of times we would order normal labs, but also a urine tox to make sure that the cause for the seizure is not a drug. Some of the common causes of seizures include cocaine use, withdrawal from alcohol, and so that's why a urine tox is obtained. We also check for infections, and then we do a CT head to make sure there's no brain bleed. So there's a full workup, but the first step is really the treatment. So in this case, because it's such a neurologic emergency, you always want to make sure to treat with the benzos and the keppra and the, stop the seizure, and then you worry about investigating and working it up. So it's a little premature that he's ordering the CBC and all the other stuff when his concern should really be stabilizing the patient right now and stopping the seizure, because status epilepticus is one of the few neurological emergencies, in addition to stroke and brain bleeds and things like that.
Seizure activity is stopped.
Also excellent.
Okay, this wasn't bad actually. I think it's a relatively accurate depiction of a seizure and the management of a status epilepticus, with a few exceptions that I mentioned, but not bad. Not too much drama, which is good. Anyway, if you like this video, let me know, and then I can do other reaction videos to this show or other shows that can be educational for you, so that you understand exactly what is going on and whether it's legit or not. Thanks again for watching, and have a good day.